Okay, guys. Well, I think thank you very much for that slightly humbling introduction. Sounds like I've done a lot more than I feel I have. But as you rightly point out, I describe myself as a consultant orthopedic surgeon and former leader. And it's a great privilege for you guys to ask me to talk here about styles of leader. Talking for a period of half an hour on this is a pretty tricky thing. But, you know, having known both Neil and Anish for as long as I have, it's no surprise that they gave me a fairly challenging task. But I did want to thank them both personally for inviting me, and also for all the effort and enthusiasm they quite visibly put into the East of England training program that we now have a very close relationship on. And I spent time up in Norfolk as part of my training too, so I've got very fond memories. I'm going to start with this slide, which is what is leadership. And I think depending on how much you read about this, you're going to find 101 different definitions, all of which will take you on a slight tangent, depending on the context in which that question is being asked. But by and large, I think this summarizes it most simply for me. It's all about making others better as a result of your presence and effort, and making sure that whatever you do is sustainable in your absence. And I think on our training program, at least, I encourage everybody to enroll in one of the various tiers of the NHS leadership program that are based around these 9 themes. But as you'll see from my talk, there's a lot of stuff that is NHS leadership driven that doesn't necessarily nurture or extract the most talent from what I consider a very unique group within healthcare, which are the doctors. And that starts from a foundation year trainee or even a medical student in my eye, all the way to consultants. And what is fairly interesting is that is there somebody else got a mic on? Is invariably leading from the middle here. And leading from the middle is something that is very unique in healthcare, because you're always reporting to people above you and asking them for resource and the okay to go ahead. And yet your responsibility is fairly vast in terms of the people behind you and how they perform, whether you're being assessed by HEE or whether it's a CQC or whoever that is. The other thing to acknowledge is, although the hierarchy sometimes makes people feel otherwise, your foundation 1 doctor is probably one of the most bright people in the country. And so you're being asked to lead very, very bright people with limited resource. The other thing I notice always in my roles is you can get to pick the team. So, you know, you often have this scenario where a football manager needs 3 years to try and isolate the perfect team in the style they want to play. And he can make sure that he has the right number of defenders, the right number of attackers, a good goalkeeper. Whereas when you inherit leadership in healthcare, you're pretty much being handed a team, and it might have 9 strikers, no defenders, and 3 goalkeepers. So bear that in mind, because it's fairly unique. Now, one thing that comes up a lot is this whole thing around imposter syndrome when you're asked to lead for the first time and knowing whether you have leadership ability or not. And I take you back to my school days. This is the first time where I recognized that I had, or somebody told me that I had leadership potential. This is my final year school report from the headmaster, and I won the headmaster's prize. And in that, he talks about social leadership and a mature and sophisticated approach has marked all 3, but most importantly, in the long term, the last as a monitor and a captain, etc. And it was the first time I stepped back and thought, wow, because I'm kind of done what I was told. And ever since, I've never really enjoyed leadership, because it is, if done properly, it's hugely draining. But I did become, as Sunny just described, clinical director at Barts Health. And literally within 3 months of my appointment, we were a consultant department of 12 people. 5 surgeons resigned. One of them very publicly had a leaked email. And so although I was thrown in at the deep end of leading in an absolute crisis, it was also, as I would encourage all of you to think, every crisis presents as an opportunity. And so it was an opportunity for me to actually have a fairly blank slate. And by fending off and reassuring both the press, the Royal College of Surgeons and the CQC that things were safe, it gave me a lot of support from the executive at the hospital. I got a direct line to them in order to help me build a department that I wanted to. And when you get that leadership role, it seems slightly crazy to me that the bright people who are going to be sitting there, and I've seen most of your CVs when you apply for ST3 roles, they are phenomenal CVs, right? You have educated yourselves at the best places, strong medical schools, you've often done ancillary degrees, and yet when it comes to the leadership piece, we're very much encouraged to sit in with the pool and do stuff that is laid out in front of us, when actually, for me, I wanted to go to the best people. These are strong universities, Ivy League universities, strong business schools. And I have a saying, which is, you're much better off being taught by the guy or girl who wrote the book than someone who's read the book. And what these institutions have is a phenomenal resource in order to help you to learn. And everything they do is just done at a higher level and in greater depth than before. And as a consequence of that education that I had, this was roughly what our department strategy looked like when I was setting out a 5-year strategy. Okay, you can see the top 3 themes, which are clinical, research, and education, are pretty mainstream. That's the foundation upon which every department is set. But then you look down at things like the brand development, or the estate and the geography, or the political development. A lot of departments don't think about that, and it's left to individuals to pursue that. Anyway, having started with that landscape, this is what our department looks like now. We have the first new professorial chair appointment in British orthopedics for 40 years, and Xavier Griffin's been appointed to that post. But we're now a department of 52 consultants from the 8 that I started with when I first took over. And that's through a period of austerity. Now, where do we learn about leadership? And I am coming to leadership styles. We learn about leadership principally from business schools, so MBA type programs of how to succeed in business. And that's largely driven on the financial return and the financial model. We learn a little bit from sport and organizational teams. We learn a lot from the military, all right, where the hierarchy is fairly rigid, but crisis performance is crucial. And then there's a little bit of taught leadership around teaching academics. And I think medics are probably the closest to that particular group. And having learned and attended courses in all 4 of these spaces, I then have set up as now the lead for consultant leadership development at Barts Health. I've, in partnership with the King's Fund, co-designed and I run a leadership program. And I've set it across 3 modules. The first module is leading yourself. The second one is leading teams. And the third one is system-wide leadership. And when people say to me, should everyone lead? The simple answer is yes, right? If you're a doctor, you have to lead, and you definitely have to lead yourself. And by that, I'll go into a little bit of what I mean, but it's really about taking control of and ownership of your life and your future and your destiny. You all have to lead teams, whether that's your firm, whether that's a theatre team, whether it's an A&E, ATLS team, but not all of us have to lead system-wide, right? And actually the people with the greatest talent to do that, who have learned to be better at it, we're all better served if those are the people who are chosen to lead us. So module 1 roughly runs along these lines. Why would anyone want to follow you? Who are you? Why are you here? What do you want? How are you going to get it? What could stop you? Who can help you? These are questions that I know every one of you, if I was interviewing you at national selection, could prepare an answer for. But, you know, without being too rude, that's all a bit of bullshit that you're feeding to get through an interview process. The honest answers to these questions, only you know. And if you can find a mentor and a coach that you can honestly discuss these with, you start to learn really about what your weaknesses are and what your fears are and what's driving you, and you just start to perform better. Now, when I run this course, this is the most ugly of the modules, because initially nobody wants to open up and everyone wants to pretend that they're much stronger than they are. But I can tell you this, if you look at the Fortune 500 chief executives, of the 3 modules, in the end, this is the one where they come back to. And this is the one that they focus the majority of their attention on. And whether you're Barack Obama or Nelson Mandela, this is the module that's going to catch you out, and that there is always space to grow. Leading a team, you can actually become very slick at fairly early. And system-wide leadership, once you know that sector, is also fairly straightforward. Excuse this being slightly rude, but it's a classic example of what I've just said, which is people learning an interview answer about what your weakness is without really ever exploring what your true weakness might be. So I've taken Martin Luther King here slightly in vain in I have a dream, but all of you do have a dream, right? Whether it's the faculty, whether it's all of you as individuals, you all have a dream, and nobody ever writes down what their dream is. And more importantly, once you're a leader, you really need to know what everybody's dream is in order to really be able to lead them well and get them to follow. So that's something that you can try and put down, but I certainly get my trainees to try and describe it when they're looking for their consultant jobs. Module 2, which is team leadership. Who are your team? What's their skill mix? What are their brand strengths? What do they want? Once you know what you are, you want to make sure that the rest of the team can compensate for any true weaknesses you have. Okay, so these are all questions that you should pose yourself. And eventually, as a good leader, you start to put a dashboard together that could look, I mean, this is a fairly random selection of images on dashboards, but you can piece that together to see how you're performing both as a leader and how your team is. System-wide leadership is a bit more tricky. And here you're looking at external influences, but also where the money sits and how you're going to get access to it. But the questions are pretty much following the same theme. And what you will hear a lot of is aspirationally, everyone says we want to be world class, but very few departments can actually describe what that means. So if I can't see most of you, but even if I look at the faculty, if you look at leadership styles, I can quite simply say that none of you, including me, were ever destined to be a leader. If you go back to the early 20th century, it was all about being a great man and your traits. And man is very pertinent there because obviously females had no place in leadership in those days. And most of leadership, whether you're looking at tribes in Africa, Native Americans, or the royal families of the world, they were all inherited. It was all believed that you were born a leader. But you can see very early on in the mid-30s, they started to change that and look at real leadership styles. And actually, it's when Hershey and Blanchard started talking about situational leadership that the real kind of study into styles of leadership began. The trend then moved on to servant leadership, which was really about serving the people you were following. But as we moved into when healthcare, particularly in the UK, started to look for its leaders, it was all about transitional leadership. And so the majority of books that you can read around leadership styles are all talking about change agenda and how you deliver change. When actually right now we're probably moving to a new space around authentic leadership. And this is where you can be honest and talk about your weaknesses, but that hasn't come to the end of its cycle. And so we don't quite know where accountability is going to sit once you expose all of your weaknesses to a team. So now, you know, I'm openly going to apologize to someone like Vikas Kanduja, who clearly should be on that slide, but is not, simply because I can't put everyone who I respect as a leader on there. But this is just a selection of people I know, people I'm friends with, people who've inspired me as leaders, and people who I've had challenges with. You know, and Mark will openly agree that Mark Bowditch, when he was the TPD of the East of England, we didn't necessarily see eye to eye on everything. We get on a lot better now. Tim Briggs, I was his senior registrar. He said to me, Prim, you don't need to learn about leadership. You know, I never learned anything about leadership, was his approach. And he's been a phenomenal leader. But what you can see as you look at all these people, whether it's Claire or Graham Titherley Strong, is they've got very, very different styles, and yet all of them are successful. All right. So I think worrying too much about what your individual style is not super helpful, as it is to understand what other people's styles are. And if you start to research on this, you will now see that there are loads of different classifications on what the different styles are, whether they're this classification will have you know, very commanding didactic leaders who do what I tell you to do, versus the really kind of coaching model of kind of what would you do next, and everything in between. And here's another, you know, this is all academically researched. So another different 5 types of leadership styles between the innovators and the stabilizers. And a lot of this, again, is to do with the context of situational leadership. What does your department need? What does your leadership role need? Are you in a crisis or are you in status quo? And the numbers can increase. Here, there are 10 different styles of leadership. But again, once you start to read these, you will see that they're all under common themes, and it's worth picking one kind of testing arena and looking into what your style is. But I think it's equally, if not much more important, to learn what the other styles are. This is something I found information. It is transformations of leadership, and you start at the bottom, which is opportunist leadership, and it's the weakest. You see it a lot in business, where people are trained to be greedy, but I won't lie to you, you can see it in healthcare too. And it's all about winning for yourself in any way possible and improving your position. Unfortunately, only 5% of people make that, because it's not a successful model for leadership. The diplomat and the expert are what you see a lot of in healthcare. You know, there you can see it makes up nearly 50%. But they focus on their expertise and want to just get along with people. They're averse to conflict. And so what they tend to do is act as a middleman in that the pyramid I described of middle leadership, a conduit for passing information down from the executive and equally to pass complaints up. What you are going to do if you're a great leader is move up into the strategist, where you are looking at organizational and personal transformation. It's much, much harder work. You do need training and support to do it. But those are the kind of people that I would encourage to push into system-wide leadership. You know, and you can see here that they understand interdependencies, and they're all about network building. And it's that combination of fierce resolve and humility that makes them successful with very intelligent people. This is another way of looking at it, which is, you know, it was very trendy for a time and it hasn't gone away, which is all about emotional intelligence as a leader. And what is successful, particularly in surgery, where you're practicing in independently, entirely for your patients, is that we do have a lot of people who are within that spectrum of very focused and non-emotional behavior. And they can often miss what the morale looks like within a department or where the empathic picture lies. And cognitive empathy is the ability to understand the emotions that you're eliciting or where the people around you are sitting. Effective is able to not only understand, but to respond to. And the emotional leader is what we're all aspiring to. The other thing is around operational leadership, which think of a trauma call and you being the leader there, versus strategic leadership, which is looking at how we can better ourselves. And in the NHS, and particularly in orthopedics, there is very little time and resource for strategic leadership. It is almost always firefighting for operational effectiveness and to get out of special measures and to get out of the next CQC report being calamitous because of the lack of resource that people have. So always think about, if you take a leadership role, what part is operational, and most of that can be delegated. And however selfish it looks, everyone's going to benefit if you spend more time on the strategic. So effective leadership, I think, is task relevant. This is the situational leadership bit. You have to identify that your behavior in a crisis is very different to your behavior in a balanced, successful department. And then when you become very successful, it's different still. And recognizing what your leadership role calls for. You know, I remember when the NHS has its IT crisis because the system had crashed, or when we had the London Bridge episode of a terrorist event in London. Really, people were put in these scenarios where they were no longer able to be objective because it was crisis leadership. And we saw some fairly average leaders in other scenarios step up because they were in their element. And yet when that died down and you went back to strategic leadership, things weren't as slick or effective. So try and understand what you are. But in order to be effective, you really need to have an able and willing group of followers. So performance readiness, both for a crisis and for status quo and for success, is something that you also need to keep in mind. And the maturity of your following, this is from Hersey and Blanchard's work on situational leadership, is whether your followers are mature, so they're very capable, and that is the majority of doctors, rather than the low group who are unable and insecure. And that's not who you're leading, okay? There may be a few who fall into that M3 category who are capable but unwilling, and those are the group that you need to look to turn around. And you will find yourself, if you're successful in leadership, being pulled towards a career in leadership. So you leave your clinical practice behind and you move into this space of being a medical director, a divisional director, eventually president of the BOA, whatever it is. And it's very difficult for surgeons because your credibility as a clinician is what gets these bright people to follow you. So my advice is never let that go, because when it comes to a crisis or a struggle, they will always look to whether you're clinically capable and credible and trustworthy as to whether they're going to continue to follow you. I'm almost at time now, so I'm quickly going to mention, never ignore the 5 dysfunctions of a team when you're a leader, whatever your style of leadership. The absence of trust, the fear of conflict, the lack of commitment, unwillingness to hold one another accountable, and an inattention to results. Now, for us in the UK, the number 5 has disappeared because of all these external reviews from HEE and the CQC. But the 2 I see consistently are number 2 and number 4, which is leaders being afraid of that conflict environment. And particularly now that everyone has moved to being diverse and inclusive, they're unable to make the distinction between conflict to clarify and make everything transparent versus the old behaviors which we do want to eradicate. And the other thing is an unwillingness, when you know who the people who are not pulling their weight, unwillingness to hold one another accountable. That is another massive failing. And I think, you know, if you guys can identify those dysfunctions now, at every step that you lead a team, you will look out for those as a sign of failure in leadership. Authentic leadership I touched on before. This is the future as we stand, which is all about being honest. Very quickly, Pam, I know I'm out of time. I've literally got 3 more slides, I think. There's this whole thing in healthcare leadership around assigned leadership, which is somebody assigns you the title. It works very well in that middle of a pyramid, and you take on the role. It means that you can't really do much, but it also means the most appropriate leaders don't necessarily take on those roles. Whereas emergent leadership is if you put a group of doctors together and they spend any amount of time, at the end of them, if you say, who would you choose as your leader if it wasn't you, because surgeons still will largely go me, they will tend to fall into groups of consensus where 1 or 2 people clearly have not only leadership ability, but the ability to attract followers. So this is my crass quote, because I mentioned this to the guys before. I've seen on Twitter a lot of junior doctors saying every leadership course I go to is full of these quotes that don't mean anything. It's amazing what you can accomplish if you do not care who gets the credit. That is so true. Everyone purports to do that. The other thing you'll hear a lot of from bosses is we always want to appoint the best people who are better than me. I'm not sure necessarily everybody does that. So what I would say to you is whenever you either do an action or delegate for someone on your behalf to do an action, as a consequence of that action, that person or you either becomes a hero, a villain, or there is no real change. If the action is not that important, it's likely there'll be no change. But in either of the other 2 scenarios, if you're a good leader, when it's the villain role, you take responsibility. When it's a hero outcome, you allow other people to take the hero outcome. And to be successful as a leader, so people will follow you, you need to have purpose. So everyone says, this is where he or she is going to take us. You have to have authenticity in that they believe you're going to take them there. And then ideally you have a track record of delivering that because they believe that you will get them to where you promise you will. Thanks again for asking me to do this. I'll take questions. I think I've gone 4 minutes over, so sorry.
That was absolutely fantastic. Thank you so much. That was truly, truly inspirational. We'll be taking questions, please, from the audience.
May I ask a question, Pam?
Yeah, of course, Mr. Kang. Please go ahead.
Hi, Prim. Thank you very much. I want to follow you again. How do we train the UK trainees, the strategic leaders? So we've got this.
That's a great and very difficult question, Neil. And I have to say, one of the problems about leadership when I'm talking to my trainees is if you become leadership strong on your CV, right? My experience is that people don't like it when you go to interview.
Be all right.
Okay. So now Deepa will correct me, and I can tell you there are a lot of people on the SAC and the TPD panels who I have seen, and they say that's rubbish, Prim. We want great leaders for the future. We're running a program at BOTA. The BOA have got emerging leaders programs. But I can tell you, when you come with a leadership strong CV as a young consultant, and the whole panel, including the medical director and the chief executive are there, they are slightly subliminal bias may play a part, but they are threatened by it. So I asked them to develop the one thing that's not threatening, ironically, is the thing that will help you the most, which is personal leadership. So personal leadership development doesn't look threatening because you're trying to better yourself. So that's the thing I tell them to make very visible. And sadly, I often, if they're really good at the other bits of leadership, particularly system-wide leadership, I ask them to tone it down on their appointment, even in their CV. I say you don't have to put everything that you've got on your CV. You're going to be strong. That talent will come across at your interview. And the minute you're appointed, and this is one of the things about assessing our programs, Neil, you know, one of the reasons the POP program is rated so highly is I don't want to look at the pass rate at the exam. Right. I know very good people who've passed the exam, and I know very average people, who failed the exam, and very average people who've passed it. I want to be judged, our program to be judged on how are the consultants performing 3 to 5 years into their consultant. And I look at people like you, and I look at people like Anish, who I know is not POP, but was Royal London trainee and was brilliant as a trainee. And those TPDs should be proud because you have gone and demonstrated how you're a team player, how you're a leader, how you can lead the people around you and take you there. So that would be my advice.
Ms. Bose, do you want to come in with a comment?
I just wanted to ask the same question I asked last week, actually, to Neil, which is that in my experience, when doctors go down the leadership or the managerial type roles, I haven't found that they've managed to influence a lot of change most of the time. Some obviously do, but most of the time I found that actually the sensibilities seem to change and the priorities seem to change when they take on leadership or managerial roles.
Are you talking here, Deepa, about their own priorities? So the easiest way to
not necessarily. I'm just talking about. I've seen a lot of doctors and a lot of nurses and medical staff and nursing staff go into leadership or managerial roles, but when they go into those roles, all of a sudden their priorities seem to shift.
Right. So I think I did understand you the first time round. The easiest way to move up that ladder, once you're on that ladder, is to be engaged with the agenda of the executive above you. And that's true once you move out of a trust into HEE or NHS England. Basically, if you're seen as being disruptive, and sadly that is my reputation, is I don't go there. I go there with very clear purpose. I am not going there for confrontation, because ultimately what we do know is there is good evidence from around the world that good clinical leaders get better outcomes for their patients. Better outcomes for their patients is what everyone wants. Think of the most aggressive manager you've worked with, the most hostile chief executive you've worked with. Actually, I promise you, however uncomfortable those environments were, they do want the best for their patients. They are often not clear or have been told to go down an avenue, job planning being a classic example, to make you deliver what they think will get them best patient care. But you have to stay strong. And that's why good leadership education, a really clear vision and purpose, and then the strength and belief to stick at it, so that once you deliver that good result and you have a time, then actually people start to fall in line and support you and encourage you. If you're constantly that disruptor who moans, so you've got a GMC survey for trainees that is red, a CQC outcome that is red, it's very hard for people to give you resource. So it's a question of really having that. And the question then would be, Deepa, to each one of these individual nurses and doctors, why is it that you wanted to lead? What was the clear purpose? And that's why I never moved up in leadership, is I only wanted to make my orthopedic department great and my trainees great. I did not want to be a medical director or a divisional director because it is hard work. And as you know, Deepa, I'm supremely lazy.
Thank you.
Does anyone else have a question? Could they please put them on the chat? So there's a couple of them coming through. So one from Hussein Taki, one of the East of England trainees. Should everyone be a systematic leader? For example, rolling I think he means a departmental rota, or should these roles be filled by people who have an interest in leading and politics?
Yeah, thanks, Hussein. I touched on this briefly in my talk. So system-wide leadership, I don't think should be for everyone. And I think a rolling rota of everyone taking their turn doesn't really, it seems like it's sensible, but it doesn't move the department anywhere. But the second bit of your question, I don't agree with that either. I don't think it should be filled by people who have an interest in leading in politics. I think you should choose, whichever department you're in, you should choose the most effective leader, the person you trust, the person whose vision you're willing to follow. And those people often won't put their hands up. And by that, I do not mean choosing the guy or girl that's most popular that everyone likes. It's somebody who understands what strategy is and understands how to go about getting it. And they have to be ruthless but fair. And it's all about trust, right? Integrity and trust are the two qualities. So that's to you, Hussein. Yaya, for starting consultant, I personally feel a degree in leadership or taking roles during training are not enough. The world is moving towards coaching to accelerate performance. Something I'm mentoring during is, what are your thoughts? So absolutely, I agree. There's a whole talk I give on coaching and mentoring. One of the things about healthcare, particularly in the UK, is everyone wants to help. I've never come across a doctor at whatever stage in my career where I said, look, what would you do about this? Who said, I'm shit at giving this advice, go and ask Miss Bose, right? They always will give you advice. So the more people you ask, the more advice you get. What is different from giving advice and mentoring is a mentor takes a vested interest. They invest in you and they feel the pain of your failure and they're brutally honest. A coach is different still. And I always use the analogy of Andy Murray's or Roger Federer's coaches. Do you think they will beat them at tennis? The answer is no. The coach holds up a mirror and says, watch how you serve in slow motion, right? And you can see the errors. So how would you go about correcting them? That's what coaching is. So Yaya, basically on my training program, I do take it on to be a mentor to everyone. And that's why people from other training programs who come to me and say, can I mentor them? Invariably, the answer is no, simply because I don't have the resource, the time and energy. And I passionately believe that good mentorship drains that out of you. With regards to coaching, we are starting to develop coaching roles for young consultants in our trust. Whether you can get that as trainees is difficult to know, but you're absolutely right about the US. So I was an ABC traveling fellowship, and that is all about emerging leaders. And I have taken this to the BOA to try and set it up. They didn't listen to what I had to say. I've tried taking it, through different channels. What we need to do is get TPDs to nominate future leaders, right? Not keep asking people who want to be leaders to join up, right? People know who has leadership ability. You guys could pick amongst your peers. If I said, all of you Cambridge guys, let's have a poll, pick the person apart from you think was going to be a great leader, right? And I'm not talking about Deepa, Anish and Neil. Then you guys will have consensus. And then we should all invest in them because they're likely to deliver change.
I have one question, if that's all right. And it's related to something that you said in your talk about how once you have a position of leadership, you have to be prepared to adapt and be flexible. And you, as far as I understand, you've been TPD since 2011. And, that's quite, you must have lived through a lot of different things. And I just wonder, how has it been different being a TPD pre-COVID, during COVID, and now as we're trying to recover from COVID?
Well, so COVID is an event, absolutely. It has been different. And this is the one area where I don't think it's through any strategic planning on my behalf. It's pure luck, and you need that in leadership sometimes. Nobody could have strategically planned for a pandemic like this, but I was very lucky in that my training program, because we're not like an American residency program where every year you get a fixed number. purely by luck, I was top and bottom heavy and had very few people in the middle. It's the people in the middle that I'm worried about. So all of my people at the top end had already met all of their indicative numbers, had hit their 1,800 cases. So although they've had a setback in elective practice, their trauma numbers have kept up, they're all going to get their ST6s, their outcome 6s at the end of training. My young trainees, I've got time, so I'm not worried. It's the middle trainees and numbers for me. They're the ones who I think are vulnerable to this, and that's a huge issue. If we move away from that question relating to COVID, how have things changed in the 10 years? The selection process is becoming far more rigid, but slightly transactional for me. So we are selecting, at least when it was face-to-face, there was a heavy skew towards bravado. So what you saw is slightly introverted, quieter, meek and mild people didn't score as highly as the people who had a degree of self-confidence, assurance and bravado at the interview. And for me, I haven't yet seen that cohort come through all the way, but when they started, they were certainly encouraged to behave in a way that lacked for me certain traits of humility and holding back, that good training programs then encouraged and coaxed out of them, so they became very sensible clinicians as they went through. The few of them who didn't, for one reason or another, are coming through sending out the wrong messages. Who's that?
I think that's Wim Herbs.
Hi, Jim. They're sending the wrong messages and upsetting not just trainers, but their peers and the nursing staff and the patients. So that was one of my worries. There's now, in the last 2 years, a trend to move away from face-to-face interviews altogether. There are so many things that make us great surgeons. And the most important thing for me is being a good doctor, empathy and caring for your patients. And somehow it is almost impossible, I think, based on a CV to get a really good feel. And me as an individual, I'm going to have biases, right? Everyone does. However woke you try and be, and you're constantly evolving. And, you know, I can tell you horrible stories about how non-diverse orthopedics was in Britain when I came through, particularly where I'm working now. Deepa will know stories, I'm sure. We've got rid of a lot of that. But yet I will bet you that if I can ask Sunny, Pam, Anish, Neil and Deepa to sit on a panel with me, between us, we will eliminate a lot of that bias that I have, and we will still have a huge amount of consensus on who we think are empathic, fundamentally caring people. Because you can train everything else. I mean, this is another talk that I could give on what I think about robotic surgery. But I think we're very short-sighted in British orthopedics at the moment to be championing robotic surgery, which actually is to the detriment, because eventually that model means that the guy who currently, or girl who currently works at the checkout at Tesco can operate the robot and do as good a knee replacement as any one of us. And actually what we have is intelligence, right? A skill set that we've trained to do, which involves judgment as well as operative ability. And then the last thing we have is our own integrity. And those are three things that nobody can take away from you, whatever happens. And to make a great training program, you have to let those three things flourish. That's my opinion.
Thank you so much. That was truly, truly inspirational.